Hello, everyone. This is Dr. Amigues, your friendly rheumatologist. Such a pleasure to be here and to talk more about positive ANA, as it's really, I've realized that I talk to my patients again and again about what is a positive ANA and what it means and how do we to understand the result that they're getting. And so I finally figured how to put both the slides as well as me talking. So we're gonna go right into it. And yeah, let's start this. So this is actually a presentation I gave to other physicians, but I can tell you that it works just as well for my patients. So I do it for both my patients and physician. And it's really a practical discussion on what it is. What does that mean to have a positive ANA? So the first thing you have to understand is that in our immune system, we are in balance. So we have a balance between our immune system recognizing something that's not ours and that we need to get rid of. So that's an infection, so bacteria, parasite, viruses, we need to get them out. The other thing is a cancer cell. We make cancer cells and our body, our immune system that recognizes them as cancerous and not ours, and they remove them. And sometimes we make antibodies against our own self. And the ANA is nothing else than that. It's an anti-nuclear antibody that is an auto-antibody. So basically an antibody that we make against our own self that targets a substance within the nucleus, so the nucleus of the cell. And that signals an abnormal autoimmune process because you shouldn't really have that. Now, before you're thinking, oh my goodness, why is my body doing something like this? We do not know what is the role of doing this. So what I mean by that is that it is absolutely possible that in the evolution of a human being, having an ANA could have prevented something else. So if you know, for example, sickle cell and malaria, having sickle cell prevents severe cases of malaria. If you don't live in a country that has malaria, you don't really get any benefit from having sickle cell. But if you live in a country that has malaria and doesn't have any treatment for malaria, having sickle cell actually prevents severe malaria. Okay, so we don't know. Maybe having a positive ANA was something that was important at one point. Maybe it is important or something that we do not know. Okay, so before you're thinking, my body is failing me, we don't know. No, there's just an imbalance, and that's something that we are learning. Okay, so ANA is a marker of various autoimmune disorders. So having just a positive ANA cannot tell you what type of autoimmune disorder you have, okay? And then the last very important piece of information is that not all ANA that are positive are created equal. And we'll go about this. So this is just an overview of a cell, the plasma cell that are making antibodies, and those antibodies are directed against the nucleus of the cell. Really just says that. And then in general, what we think, and it's actually not that easy to prove, but what we think in science is that first you have the positive ANA, then that positive ANA causes inflammation and tissue damage. And it's when you have tissue damage that you actually develop an autoimmune disease or condition, okay? So we know from previous studies, particularly our veteran studies, our army studies, that you usually develop a positive ANA years before you have a condition. And so you'll see if you have a very high positive ANA and you have family history, it is recommended that you follow up with a rheumatologist so that we make sure you do not develop an autoimmune disorder. But since it can be years, that doesn't necessarily mean that you need to be on anything if you have no symptom whatsoever, okay? So the really important piece, and this is more for physician than patient, but actually I think it is important for patients, is that you shouldn't have an ANA tested if there is no reason for it. It is not a test that you check just like that, because it's going to actually create stress and anxiety. And it's really not a test that's, preventive. Like, it's not like, oh, look, you have a test that's positive, so we can prevent something. No, because we're not going to do anything if you have no symptoms. So if you have no symptoms, don't trigger stress in you by checking an ANA, okay? Only if you have symptoms. And what are the symptoms that should trigger a positive ANA? And so they are the symptoms of autoimmune disorder that are going to have a positive ANA. So it's mixed connective tissue disorder, if you have Raynaud's phenomenon, if you have joint pain that's inflammatory, so worse in the morning, associated with morning stiffness, with swelling, and that's improving with exercise. If you have any changes of your skin that are tightened, if you have dry eyes, dry mouth, if you have rashes, hair loss, shortness of breath, chest pain, and you're young, if you have those and you're young, if you have fever and you cannot explain the fever, those would be reasons to check a positive, like an ANA, okay? But as I mentioned earlier, not all ANA are created equal. And what's really important for you and to understand is that there are two types of tests that are going to check for positive ANA. And there is one that's very cheap, where we can do multiple tests all at once, and that's called the ELISA. And while it's an okay test for other antibodies that are much more uncommon, much less common, it is not the perfect test for an ANA because it doesn't give us enough information. Okay, so that would be let me share with you the one that I like to use. So it's the one with immunofluorescence. So what we're seeing is that we're taking someone with blood. We're taking the blood, and we're basically diluting the blood into a plate where there is antibodies of ANA that we put fluorescence on. And it's that fluorescence, if you have antibody against the ANA, if you have ANA in that blood, the antibody that has fluoresceinated, right? Like, so those fluorescents are going to pick up the ANA, and that's what you're going to see after you wash it, because, right? So we're putting the blood, then we're washing with those fluorescein antibodies. And then if you do have antibodies that are positive, we can see it under the microscope, okay? So basically, you have an antibody that has a marker that you can look at, and you're looking if you have ANA, because if you don't have ANA, the marker will just get washed off because there's no reason for it to get sticky on the plate. Okay, so that's actually it's not that easy to understand, but once you understand that it's kind of like a Lego. You have Lego and you have the piece that goes directly on the Lego, and the way that you're seeing the piece is that you're seeing the fluorescence, okay? And then you're looking, and when you're looking if there is, number one, if there is positive ANA, and number two, what type of ANA those are. And we have homogeneous, speckled, peripheral, nucleolar, and centromere type of antibodies, like of ANA, okay? And then this is the same thing: speckled, homogeneous, mixed, nucleolar, centromere, peripheral. And this is actually exactly what we see. And so that's number one. Very often when there is an ANA that's not that important, that doesn't mean much, it's usually homogeneous, all right? When there is other type of ANA, and this is why I was telling you I don't like the direct ELISA, I like the immunofluorescence, because I want to know what type of ANA those are. Is it speckled, mixed, nucleolar, centromere, or peripheral? Because they are going to tell us what maybe this is, like, what's going on here. And then the second thing is to understand those titers. You probably have heard, oh, I have an ANA of 1/80, or I have an ANA over 160 or 1/320. It's just a dilution. So you take the blood, you dilute it by once. It goes to, if it's positive, it's 140. Then if it's still positive, you dilute it one more, and then it's 180. Is it still positive? You dilute it one more. So you see it's doubling the dose every time, the number 1/160. You diluting it another time, 1/320. And you do like this by, diluting half every time, and you can go to 1/5000 and something, right? So you multiply 1 over 320, then 1 over 640, then 1 over 1280, and so on. And that's really what it means. So the dilution, so when patients are scared because they went from an ANA of 1 over 40 to 1 over 80 or 1 over 160, and they're like, oh, look, my ANA actually has improved. It's now 1 over 80. You do understand, or 1 320 to 1 over 160, of 1 320 to 1 over 640. Those numbers, they are scary, but really it's just one dilution. And one dilution doesn't mean much. And so I don't want you to worry about one dilution. When you have a positive ANA, we tell our patients not to check it again. There's no reason to check it again because this is a screening test for an autoimmune disorder. So that's, I don't want to go into this. I think what's interesting is to realize that we don't stop at a positive ANA. If you have a positive ANA, we recommend to check then for autoimmune disorder. And those are the ones that we're going to check. If you have a nucleolar, and honestly, I usually check for all of it. But lupus, rheumatoid arthritis, discoid lupus, erythematosus, that's the DLE. In speckle, we check for lupus, for mixed connective tissue disorder, for scleroderma. Peripheral, we check for CREST, which is a form of limited scleroderma, for lupus, and so on. And you can also check, this is not here, but you should check for Sjogren. So here, also overlap syndrome, scleroderma, those are the ones. Lupus, we've already talked about. And then you can actually look for this. And there are antibodies that are specific, more specific for lupus. So, right, like Smith antibody, dsDNA. And then for scleroderma, it will be, do you have centromere antibody? Do you have STL70? Do you have RNA polymerase free? That's more for scleroderma, or PM/SCL 170. Those are like of other antibodies that are positive. And so an ANA by itself doesn't tell us. But very often we are stuck with just a positive ANA. And so again, what are the positive ANA? So it's lupus, scleroderma, MCTD, Sjogren, other rheumatologic disease. And then you have to remember thyroid autoimmune disorder, which is the most common autoimmune disorder, is Hashimoto, right? That also causes a positive ANA. Rheumatoid arthritis can cause a positive ANA, but also infection. So HIV, chronic hep C, that can cause a positive ANA. And so that's our role in rheumatology, if you have a positive ANA, to rule out also those other causes that are not rheumatologic, okay? And then, so another reason why the ANA is not all created equal is that if you take a full healthy general population that they have zero symptom whatsoever, we just check their antibodies, you will see that 1/3 of the population has a positive ANA. It's just that it's 1 over 40 at max. That 13% of the general population has a positive ANA that goes to 1 over 160, and that only 3% of the general population has more than 1 over 320. You also see that the positive ANA is more common in elder patients, right? So 20%, that's a lot of patients that have positive ANA. So when we check your ANA and we see that it's positive, we look at it in that context. How high is it, number one? And then how high is it? And then like how old are the patients? Like how old is our patient? And then what type of ANA is it? Is it a low ANA that is homogeneous? In that case, there's not much worries. Is there no family history, or is it something that's speckled or centromere and or high titer? Okay, and in a young patient. So it's important to realize that that we have not like we should check an ANA only in patients that have symptoms that can be autoimmune, and we need to make sure that everyone is educated regarding this. And I put that picture because normally I put this for my patients when they're one-on-one, and I put this for physician and practices that are not specialists. But if you have any question, don't hesitate to ask them, okay? Hi, Rock Doc. I'm going to just see. Hi, Dawn. Hi, Dr. Mona. Hi, Dr. Singla. It's such a pleasure to see everyone. If you're seeing this after, please put a hashtag replay. And this will actually live on the website positiveana.com. So please don't hesitate to look at positiveana.com. If you know someone that's worried about the Positive ANA, share that video that will be on the positiveana.com. Let's make sure that people are getting answers. Let's make sure that everyone is not worried anymore. Okay. And if you are worried, know that I see new patients and we make sure that we see them in a timely manner within 2 weeks. And sometimes, if needed be, we can do it earlier or later as you prefer. And it will be my pleasure and honor to take care of you. All right. Take care, everyone. Have a wonderful week. See you next week.